Hi everyone, welcome to the first session of our second day of this conference. This session is called Digital Sexual Health, What We Need to Know and what we need to know for effective services. Claudia, I'm sorry, I probably messed up that title. You can correct us. My name is Ingrid Young, and I'm going to be both the host and the moderator. And Claudia, this is Professor Claudia Estcourt. She will be talking to us about her work. She's based at the Glasgow Caledonian University, but wears many hats and does many things in Scotland and elsewhere. So I won't begin to list all of the things that she does. But before we jump into that, I just want to remind panelists and audience members about our terms and conditions that we've all agreed to. We have a zero tolerance policy for attack or abuse. We would just really like to encourage you to be here in the spirit of active listening, discussion, and respectful debate so that we can all work together to address the challenges that face us in sexual health, well-being, and social justice in Scotland. I'm going to pass over to Claudia, who will now talk about all of her amazing work and all of her projects, and we look forward to hearing from you. Thanks very much, Claudia. Over to you.
Ingrid, thank you for such a kind introduction and welcome everybody. I'm not just presenting our work, hopefully we'll be much less parochial than that. What we're going to do is go through what I think are the key questions for really delivering exciting, ambitious, safe and inclusive sexual health care online. I'm aiming to talk for 40 minutes max, so we have time for discussion subsequently, and I really would welcome your questions. For some of you who attended the ISS TDR conference in Amsterdam or online in the summer, you will recognize a lot of the slides, so good time for a cup of coffee and join us afterwards for the chat. Next. Thank you. Next. So really what I'm aiming to do in this session is thinking about us being how we can be delivering ambitious, safe and inclusive and clinically and cost-effective sexual health care in a digital world. That's really important distinction. I'm not just talking about online care, I'm talking about digital healthcare in the context of health and in the context of people's lives. And the graphic on the right-hand side of the screen is from the WHO. And I think if the WHO are saying upfront at the start of their publications that digital health interventions should be integrated into health systems and not some standalone add-ons, we should take this really seriously. And that's one of the key themes throughout this talk. Next, please. Over the next short while, I'm going to give you my vision. Could you go back, please? For what optimal digital sexual health looks like, what the current landscape and evidence is, where are the gaps in evidence, where there might be challenges and risks as well as huge potential, and where I think we should be looking next. Next, please. I'm going to start just by looking at some definitions, and these can be a bit confusing because they're emerging and people use them interchangeably. I want to stick using digital health predominantly, and I'm taking it as the WHO definition, which is the convergence of digital technologies with health, healthcare, living and society to enhance the efficiency of healthcare delivery. Precision medicine, which is about tailoring your medicine either genomically or according to various other parameters to the individual, is not what I'm going to be covering today. And to put it in context, I think there are 58 countries of the world with published digital health strategies, ranging from Australia to Tanzania and others, beginning with Z down the list that I've not put on the list. Next, please. So this is my vision of optimal sexual health, and it's not just me being egotistical, it's looking at the literature and some of the things that are emerging in terms of what people who use our services or we might wish to use our services want. So I think what we're really looking for is an e-sexual health clinic, a seamless, supported, end-to-end experience online for those who want it, but for those for whom it's inappropriate clinically or who don't want it at any particular point that they're seeking care, people can switch between online, telephone, face-to-face services according to their preferences and clinical needs. It's got to have real-time specialist advice and support, not just some generic help pages and FAQs. I think we should be delivering whole clinical care pathways online where all elements of care are included. So it's not good enough just to be able to send for a postal self-sampling kit online and then have to work out how you engage with treatment face to face. You should be able to do that online if it's clinically safe and appropriate. Things need to be joined up, not fragmented. So if I've been seen in clinic one day, and then go online a few weeks later, I would expect all of that information to be available to the clinic or to my clinician the next time I see them. And then we need to be expanding outside of the clinic, links to community pharmacy, for example, to injecting drug services. So we really are integrated and very much not just a clip-on standalone. Next, please. So what does that mean at individual level? It needs to be acceptable to people with diverse and changing needs and preferences. We need to be creating systems and healthcare that addresses inequalities. We know they are already huge, and these need to be presented so that people can have a choice and that no one modality of care is mandated, unless, of course, there's only one clinically safe way to provide that care. And I think we could have great gains by streaming people with less complex needs or social circumstances online into self-managed care, creating capacity for more complex people with more complex needs to be seen face to face if that's appropriate. And again, we're in the real world. How can we use this to create economies of scale? Well, in Scotland, we have a perfect opportunity to do this. We talk to each other. Health boards talk to each other. We have an integrated sexual health clinical record system. So this is tractable in Scotland, and it's a problem that we can solve. Next, please. Next, please. Where does the evidence stack up to date? We are not talking about people's good ideas unless good ideas are backed up with evidence. Too much money has been lost with good ideas along the way, and too many good ideas have been developed without the evidence to really promote their care more broadly. So the majority of evidence to date comes from postal self-sampling services, which have gained a huge amount of traction in England and in the other countries of the UK. We're a bit slower in Scotland, but getting there. Much less data is available on the clinical and treatment outcomes of those who seek sexual health screening online, and very little has been done about online partner notification and partner management. So I'm going to touch on cost effectiveness, accessibility, some other modalities of care such as video consultations or telephone consultations, a little bit, but not much, about photo diagnosis and AI chatbots. Next, please. I want to make this user focused. I think it's a really obvious place to start. We're designing systems that have got to meet needs of the people who use them or the people we would like to use them, depending on their particular needs. So I'm going to start with a very simple progression from somebody who has a symptom or a concern that they think might be STI related, helping them determine what it might or might not be. How can they get tested? And then if they are found to have an infection, how can they access appropriate care that suits their needs? And then how do they protect their sex partners and others and themselves in the future? And how might they enable their sex partners to get tested and treated? Next, please. So looking at awareness and engagement, some really nice work's been done both by my team, Dr Joe Gibbs from UCL, and the teams in Melbourne Sexual Health Clinic, looking at how they can provide information online that's safe, that's appropriate, to enable people to take the first step in finding out about their symptoms and where they might want to go to access testing and treatment. But of the apps available, we found, looking at those apps and doing a systematic analysis of the safety of the language used, that many apps contained partial information that's either distressing or downright inaccurate and could lead to problems. So it's a very unregulated field and difficult for people to navigate what's legitimate information and what really isn't. Next, please. In terms of getting tested, there are a number of different scenarios which I think many of you may well be familiar with. We've looked in detail, as have others, about postal self-sampling, where somebody at home logs onto a website, answers some questions about their risk and about their anatomy, and then as a result of that, requests a postal self-sampling kit. The kit's sent to their home or an alternative address, and they take relevant samples for STI and bloodborne virus screening. What we know from the data published to date is that higher proportions of females, people of white ethnicity, and those who have lower measures of deprivation use it compared to clinic-based testing. It can certainly effectively engage with some people who experience barriers to traditional testing options, but what it does do, again, is tends to appeal to those who are already pretty good at accessing services. I think that's changing, and there's some nice work from our Canadian colleagues, Mark Gilbert and others, who have shown in certain populations it is reaching those who have other barriers to accessing face-to-face services. So it's mixed, but I think if we're looking at it as a tool to reach those that we're finding harder to engage with services face-to-face, we need to be very careful that we're not being overly optimistic about what it can achieve. Next, please. In terms of detection of infections, it tends to have a lower positivity than clinic-based testing. That's not surprising because mostly people with symptoms are routed into clinic, and it's not insignificant. So it's not that online self-sampling is just giving negative results the whole time. However, and I think this is really important, people with even mild intellectual disabilities will struggle with online postal self-sampling. And this could easily increase health inequalities if we're not careful. I'm going to come back to that later on in the talk. And we know that certainly throughout COVID and beyond, an increasing proportion of sexual health screening is going to happen online, almost insidiously. So this is something we need to take seriously and be very mindful of what we want it to do, who it's likely to reach and who it won't. Next, please. This is a study, the Zenzeli pilot study, looking at HIV self-testing, and this was done in sub-Saharan Africa, in KwaZulu-Natal, in South Africa. And this is really looking at the potential for digital to go beyond our settings, to go into settings where there's a much higher prevalence of HIV, where actually it's not so much the testing that's the issue, it's the linkage to care, where people fall off the care pathways. So some nice work happening with collaborators in the RE Centre and at UCL that showed even in countries where there's relatively low literacy, in addition to digital literacy, there's a high acceptability for self-testing linked to care pathways, not for self-testing where the user is just completely independent from services, but where the self-test is accompanied by a wraparound linkage into care for those who test both reactive and for those who test negative. Next, please. So what about video consultations? I think many of us throughout COVID may well have had a video consultation with a healthcare professional or even a vet, which was interesting with my dog who wouldn't perform according to need. And so many of us know at first hand how great they can be and what the limitations are. They've not been used extensively in sexual health medicine, largely because we often examine people. And I think a lot of people experience barriers to exposing their genital anatomy in their home setting and filming that so that a clinician might be able to look at a lesion or look at an ulcer. In addition, I think we've got to take very seriously some early data from Australia that suggested that young people were actually much happier with telephone than webcam. So just because the webcam is there doesn't mean that people necessarily want to use it. And that was about privacy. It's much easier just to hang up on your phone than it is to get round to closing your laptop very quickly if someone comes into the room. But that was 10 years ago, so I think acceptability is growing. But I think really we have to be, as with my clinician hat, very clear that a lot of times it's not enough for me to examine somebody. I actually need to do an internal examination. I might need to lay my hand on their stomach. So just being able to see something isn't necessarily going to help me any more than speaking to somebody on a phone. I either need to see them in person to examine them or I don't. I think Moving to sort of slightly newer technologies for health in terms of AI chatbots, there was a nice paper published recently suggesting that they're certainly capable of promoting health, education, and maybe behaviour change. And users were quite receptive to the idea, but just a little bit hesitant. Again, I suspect that may change over time. This degree of automation, of course, is appealing in terms of funding healthcare, but again, we've got to be careful that we're looking at the right modality for the right person at the right time. Next, please. What about accessing results? Systems around the country use different means. A lot of people receive texts to say their results are ready, or a text to say these results are positive, this result is negative. We found from some of our studies that people found an alert text to say your results are ready, to let them know that they might wish to go to somewhere private to access their results, was generally more acceptable than a text that actually could be your phone on your desk the wrong way up, or in a lecture saying, oh, your chlamydia results positive, here's what you need to do. I think that becomes really important for HIV self-testing. Work which we and others have done have shown the absolute paramount importance of providing clear instructions, linkage to care, and emotional support. We cannot expect people to navigate their own health at times of quite high emotion, whether someone is positive or reactive or negative, in isolation. We have a duty to link them into care and support as appropriate. Next, please. Moving on now to management of diagnosed infections, and this is our research. We're just in the middle, or just at the start of a new program which builds on early work from a few years ago, where we developed an online sexual health clinic, which enabled people with a positive chlamydia result to undergo an online automated consultation, which could lead to prescription of antibiotics to be sent to a community pharmacy, or for them to pick up from clinic. It's the first example of a completely automated consultation and prescribing pathway anywhere in the world. This has economies of scale. It leads to and has shown early evidence of effectiveness in terms of increasing the proportion of people receiving prompt and early treatment. We are at the moment getting ready to optimize that system, ready to conduct a randomized control trial to look for clinical and cost effectiveness and safety out with large numbers of people. Next slide, please. The user element of this looks as really very simple. They access the consultation on their mobile phone, and we have designed with human-computer interaction and health behaviour principles in mind to make it as simple and easy as possible. This should not underestimate the very complex system that lies behind that experience for the user. And as I explained, if you look at this diagram from left to right, somebody who's diagnosed chlamydia positive, other tests negative, is invited to log in, invited to undergo the online consultation and receive their treatment. Behind all of that is an option for them to enable their sex partners to log on for testing and treatment, an option for the community pharmacy when they go in to collect their treatment to tick that and log that that person has collected their treatment, a surveillance function where we're looking at the parameters you would expect for public health reporting, and also a clinical helpline where people who experience difficulties with the system, forget their logins, or people who have symptoms that mean they need examination are helped remotely, eased into clinical care or back onto the pathway as needed. Next, please. So what about health outcomes? And one of the things I think people get sick of me saying is it is not enough to have a system that looks nice. It's not enough for people to say, oh, I quite like the idea of that. We have got to show that it is delivering high quality care to national standards. And there's absolutely no point in doing it if this is either not cost effective, or it may cost a bit more and is reaching people who are not reached by current options. Generally speaking, clinical outcomes tend to be poorer. Now, what do I mean by that? I mean that if somebody has tested through a postal self-sampling service, generally a slightly lower proportion of them actually get treated compared to people undergoing that in clinic. Now, most of that data was pre-COVID. The world has changed dramatically, so I think we need to bear that in context. In contrast, in our proof of concept studies, we had higher treatment rates and treatment was achieved faster. But the reason we're doing a trial is that that was proof of concept, and we need to look at that definitively. There's almost nothing on partner notification outcomes for those tested and treated online. And if we look at how the characteristics of people undergoing treatment through different routes, one recent study I think was slightly problematic in that they reported similar demographics and numbers of asymptomatic chlamydial infections detected online and in clinic, but it didn't report on the demographics of testers, so you're not really seeing the whole picture. One economic study done in London looks like the cost per diagnosis for online services could be less than clinic delivered care, but it's really important in that to look at what they defined as the clinic/online positivity ratios, because that's the devil is in the detail at that point. Next, please. So thinking about the health economic considerations, the most important point I think here is that we're not just looking at one tiny element of care, we're looking at a whole care pathway. So somebody with chlamydia, for example, if testing them through online postal self-sampling is cheaper than in clinic, great. If treatment is also cheaper than being done face-to-face in clinic, great. And if we're getting the same contact tracing outcomes as we are in clinic, done online, fabulous, it's clearly a winner. However, if the online postal self-sampling is cheaper, but the treatment may not be cheaper because we're spending time chasing up people because they're not coming back to services, and likewise, if it's harder for us, we're spending more time contact tracing their partners, we need to look carefully. And obviously, if you look at the bottom, there's no point if testing is cheaper if both getting good treatment outcomes and contact tracing outcomes costs more, because we need to devote more resource to it. Next, please. So what about health promotion and behaviour change? There's a great systematic review from Elizabeth Wadham's group, and I think the quote in the yellow box really sums up some of the findings from the study. And I think we just need to remember that digital media sexual health interventions can certainly increase knowledge, and there's evidence for a small increase in confidence in people's ability to take those steps into promoting and protecting their own health. However, when we look at harder outcomes like condom usage, the data is very mixed. So I think I would say there's considerable potential, but again, we shouldn't just assume it's all going to be easy and this is all we have to do. Next, please. Next, please. I now want to talk about equity and providing equitable services. We talk a lot about this in Scotland. We know what inequity looks like, but we also know there's an awful lot of inequity that we don't see. And I think I'm preaching to the converted here, but it deserves to be said that inequities in health do put groups of people who are already socially disadvantaged at further disadvantage with respect to their health. Next, please. And I think that's important when we design our systems, when we look at outcomes for our systems. And it's also important when we're trying to keep people safe. And a lot of work has been done in terms of clinical safety and safeguarding, and some very nice work's been done to produce guidelines for this, and some studies which are being led by BASH and the Faculty for Reproductive and Sexual Health. I think that's going to become even more important over the next few years, and it's just one area that could almost be an hour in itself and more. Next, please. If we move now on to digital health literacy and the digital divide, I think we've ignored this. I know in the research setting, health service researchers have been far ahead of us as clinical providers, and I think the worlds are only just starting to overlap. I think many of you will know Don Nutbeam's work. There are other models of health literacy, but I find this is the one that works for me when I'm thinking about our systems, in which health literacy, and I'm adapting this for the digital context, is divided into 3 levels: functional, interactive, and critical. And if you think about this in the context of digital health, we get the concept of the digital divide. And this is the economic and social inequality with regard to not just to access, but to the use of or the impact of information and communication technologies. Next, please. So summing up what this really means for me is just because the person in the waiting room before they come in to get their screen is very happy to use Snapchat, to use Insta, this won't necessarily mean that they are using online banking, which requires much more cognition, balancing of complex concepts in their head. And that doesn't necessarily mean that they are willing or able or have had experience enough such that they can navigate complex clinical care pathways online, such that automated treatment or other elements of their care are safe to be delivered through that platform. Next, please. This brings me on to barriers, and I think whilst there is massive potential with online sexual health care, we need to be extremely mindful of barriers. I'm going to go back to the study I mentioned briefly, researching with people with mild learning disabilities. This was a study which we led as part of our Lustrum programme of partner notification work. And what we were trying to do was to see how we could make postal self-sampling packs for STIs and bloodborne viruses really more acceptable and feasible to people with mild learning disabilities. And this was focus group work where we presented people with, very proudly, with the packs that we'd already optimized based on work with people who did not have mild learning disabilities. And we thought we were just going to get the icing on the cake. And I think this is one point in my research career where I really felt disappointed in myself, because I really had not understood the barriers that people with even very mild learning disabilities face when it comes to understanding information, when it comes to manual dexterity, when it comes to navigating their health, when health is increasingly pushed on people as a DIY or self-managed process. I'm happy to pick up questions on that later, because I think it's tremendously important. And I think we sometimes overestimate people's abilities, people's experience, and people's desire to manage their own health and their own care, especially if it's online. To say nothing of poor connectivity, having insufficient money for credit on smartphones for data, and also privacy. In some countries of the world, it's very common for people to share devices. So we need to be mindful of that when we're talking about care delivery online. Next, please. So the next few slides, I don't think have received enough attention yet, but I think they will as we move forwards with online care. And I kind of summarize this as complexity and the Amazonization of sexual health, or the Amazonization of clinical care. And I think some elements of healthcare and sexual healthcare can be very easy and very transactional. I want this as a user, the system can give me this. However, sometimes what an individual patient wants is not what we as a clinician feel are the appropriate tests or the appropriate treatment for the symptoms or health concerns they have. Now, I'm sure you're thinking, gosh, that's terribly paternalistic. I would refute that. I think there are some circumstances where the patient is exactly clear on what they want, and they are correct in terms of what medically they need to satisfy their health need or perceived needs. But in many situations, I think there is a mismatch between what a patient feels is the appropriate investigation, test, or treatment, and what clinically is the appropriate set of tests, investigations, or treatment. When people go online, our research and others has described a process where they become the customer. And I don't use customer in a healthcare context because I think it's important not to. If you are a customer, generally speaking, if you pay your money, you get what you have ordered. In a healthcare setting, it is a conversation. It's a joint decision making between clinician and individual as to what is right for them at that particular time. And I think that's important when we go online. So, for example, in our online treatment pathway system, even though we described to people that there would be instances when if, for example, they reported particular symptoms, they would need to be seen face to face. People got really angry about this because their viewers, well, you told me I could do this online, and that's what I took on. And now you're saying I can't, and I've got to come to clinic. I'm angry about this. So I'm going to illustrate this going forwards. Next slide, please. Next, please. So an example of this from clinic a few weeks ago was a young man who came in and said, I just want a syphilis blood test. Next page, please. So after a couple of minutes of discussion, I'd elicited that this young 18-year-old man who has sex with men living in inner Glasgow had symptoms such that I needed to examine him. There was also opportunity for him for us to help him improve his health and help him protect against future infections with hepatitis B vaccine and HPV vaccine. He'd never had an STI screen in the past, and there was also huge opportunity to let him know about PrEP to enable him to make informed choices as to whether that was right for him going forwards. And he definitely did need a syphilis blood test, but as a part of that consultation, the syphilis blood test would have been medically inappropriate without a fuller consultation, without an examination, such that treatment was actually required on the day. But his first presentation, in terms of this is what I want, this is what I'm expecting, there was a mismatch. Next slide, please. So this brings us on to complexity. Now, complexity within sexual health, I think this extends across medicine, but I think within sexual health, there are particular issues which may make online services quite challenging. So I see this as three independent or overlapping, constant or fluctuant components to people and their medical presentations or clinical needs. So these might be clinical, the symptoms they're presenting with, what we find on examination, the other healthcare issues they have, whether or not they might be pregnant at the time. Their level of risk of infection, so by virtue of their behaviours, their sexual behaviours, or the types of people they're having sex with, how likely or unlikely is it that they will be susceptible to particular infections? And then overlaid on this, the socio-personal factors, the young, the people who might be vulnerable for a whole host of reasons, people with low health literacy, people who might be engaging in sex work. Now, these overlap and they may change with time. And I think it's very difficult through online systems to get a handle on this and to produce systems that can consistently adapt and change to the needs of an individual who may change between these categories. Next, please. So I'm just in the next few minutes, I'm just going to sum up what I think we know so far, the unanswered questions and where we might want to go next. So pulling all of this together, I think although the evidence for the effectiveness of online clinical care is lacking, there's a lot happening and the evidence base is growing. Everything has changed around us even before COVID, and I think delivering more sexual health care online is becoming even more important. But we need to use it appropriately and we need to use it with care and we need to have much greater ambition as to what we can deliver online for those who want it and for those whom it's safe and clinically appropriate. But that means it must be acceptable to a wide group variety of people across the population, and it must prove that it's efficient for the right patients at the right time. And when we're designing and evaluating our systems, the possibility for health inequalities and exclusion needs to be right at the centre of what we do. Next, please. So the key areas for research, well, I think we need to look at what is and what is not cost effective for whole care pathways. That's avoiding the fragmentation that I talked about before. We need to look at how inclusive we can make digital services and be very honest when we say there is actually a barrier. No matter what we do, there will always be a barrier, but we need to measure that and we need to ensure that we're providing and offering suitable alternatives for people who at any particular time cannot or do not want to access treatment online, and how we best guide them to the most appropriate modality of care. We've got to be looking at advances in easier self-sampling for tests which are currently done on blood samples. And I think there is innovation there going forwards, because we know this is what people find the most challenging. And I think we need to look at improving connectivity. This isn't just in the UK, but obviously it does affect areas of the UK, and think about digital poverty issues as well within this. People who don't have phones, people who only have credit from time to time. Next, please. So what can we do now? Well, we can certainly overhaul our paper-based legislation. It will not be a surprise to many of you to know that most of the health regulations which exist, not the ones that people tell you are regulations but actually aren't, the proper ones, were meant for a paper age. So they just need updating, but they need bills in Parliament, and that just takes time. And Parliaments, no matter how good or badly you think they've dealt with COVID, have been rather busy of late. We need to think big, and we need to think integration. These things must be seamless. We need to know what right and left hands are doing. We've got to evaluate, and we've got to establish evaluation frameworks that really capture big things. We can't just measure the things that are easy to measure, because they may not be the important things. We've got to think about our staff too. Many of us hate spending days doing telephone consultations. Most of us went into clinical care because we like seeing people. We've got to think about how we modify our training within the workforce, and we've got to think about people's jobs, and we've got to think about what gives people job satisfaction. We must co-produce. We've got to bring in multiple stakeholders, and we've got to be on this journey together. And we need to be providing face-to-face alternatives. I've flagged here throughout our logo and the word Sequence Digital. And this is a big program of research that I alluded to initially, which is where we're looking at improving sexual health for all in a digital NHS by looking at how we can use complex clinical care pathways online to their best effect, designing for maximal inclusivity and reach. And I'd love to talk to you about that at some point in the future. Next, please. So just to finish, what's happening elsewhere? What's happening on the horizon? For those of you who don't know Mark Gilbert's work with Get Checked Online in Canada, there's a rich seam of work there and some really lovely research looking at inclusion. In terms of delivery of healthcare, what they do is they get people to request a test online, print out forms, and go to the lab for sample collection. So it's not quite the same. Data from Emerge in Europe, which is looking at how people can access PrEP online, and that's work that we're also doing in Scotland through the ePrEP clinic. Assist is a really nice evaluation program based at UCL and Birmingham in the UK, looking at large-scale evaluation of online services within the wider sexual health economy. And just prior to this meeting, I was talking to collaborators in Melbourne, and they're trying to design something similar, an e-sexual health hub, where they're bringing together some of these elements targeting people under 30. Next, please. So just to come back to Sequence Digital, and I'm just blatantly plugging it again before I do my goodbye slide. Please have a look at our website. That's on the first slide, sequencedigital.org.uk. Get a flavour of what we're up to. And please do contact me if any of the work on the website is something with which you're interested. Next slide, please. So thanks to everyone who's helped with this presentation, the myriad slides that have been lent to me, the other wider Lustrum team, Sequence Digital team, and those mentioned on the slide who provided data, evidence, and opinion. And thank you all for your time this morning, and I'd be delighted to hear your thoughts and answer any questions.
Thank you, Claudia. I think we can get rid of the slide, please. And there have been a few questions that have come through. Thank you. That was a whirlwind tour of lots of really important issues, and we could probably spend the next few hours unpacking a little bit. I'm gonna flag up some of the questions that have been asked during your talk, and for those of you who are with us, feel free to put more questions in the chat box or the Q&A, and we can engage with that. But there was one that came on early in the talk. I'm going to show it on the stage. So this is from Lewis Clark, who asked about what do you think about the future of AI chatbots with regard to the integration of this approach in the sexual health testing and care journey? How can hesitancy be reduced and their use facilitated? Can you
Gosh, what a nice PhD that would be. Lovely question there. I don't know is the answer to that. I think, like everything in digital, we've all got examples from our own experience of, for example, an app that's brilliant and an app that is characterized by a four-letter word that starts with C and ends in P. And we know intuitively the apps that meet our needs, and we also know lots of them that are just completely and utterly rubbish. And if you have a rubbish product within health, you rapidly lose confidence of the people who want to use it. So I think with anything, I think there will be the potential for a fantastic quality offer that could help with certain aspects of care seeking information. But I think we just really owe it to users and potential users of services to put the hard work in to make sure that that is really high quality, really meets people's needs and is co-produced. So potential, I'm sure there is, but I think there's also potential for completely disenfranchising people, as there is with any digital intervention and with face-to-face care, if we get it wrong.
Thank you, Claudia. I'm going to move to the next question, which links a little bit to what you just said in relation to co-production. So Rachel asks, does your conceptualization or vision of Scottish digital health include peer-to-peer communication and support?
I think that's interesting because it's a shame we're not face-to-face, because I would be asking you what sort of peer-to-peer you think would be helpful in this respect, because it's a beautifully framed, another fantastic framed question, but it's huge. And I think I'm probably going to disappoint with my answer here, because I think it depends which element of care you're talking about. I'm going to move slightly aside, and I do want to talk about peer navigators, because I think in certain circumstances, a peer navigator, which was some data that's presented again from the Canadian group and some nice publications on this, are brilliant for helping people who might struggle but have a general desire to access care online. I think peer navigators could have a fantastic role in doing this. I'm not sure at other parts in the pathway what roles, I think it's a nice research question, peer-to-peer interaction would have, because I think we need to be very specific at which points in the pathway, which infections we're thinking about, because I think there is probably a big differentiation between treatable, curable STIs and treatable but perhaps not curable bloodborne viruses here.
Claudia, I'm conscious of time. I'm gonna pop one more question on stage from Donna Payne. So she asks, regarding digital partner notification, is there something we can learn, or what technology can be adapted from COVID contact tracing in Scotland? This is obviously not a small question, but if you could respond in a few minutes or have thoughts, that would be fantastic.
I think what I would commend you to, and I'll put it in the chat, we've done a webinar as part of the Lustrum programme where we got epidemiologists, public health experts, partner notification practitioners to look at what COVID-19 can learn from STI contact tracing. I and others, as the reports have come out, have systematically suggested that COVID contact tracing has not been effective in controlling transmission. So I do not believe that there is much from the England or the Scotland contact tracing systems for COVID that would bring benefits in STI or bloodborne virus contact tracing. I don't say that lightly. Conflict of interest is that early on in the pandemic, I spent time working with Public Health Scotland and Public Health England, as many of us did in the field, with long track records in contact tracing and management to try and help design systems. And we realised quite early on that the way that we were looking at systems, the way we were looking at behaviour change, the way we were looking at really reducing barriers to getting people to do the right thing was very, very apart. So I would say it's the other way round. What could COVID contact tracing learn from STI and bloodborne virus contact tracing? And I will try and very quickly and pop in the chat a great webinar that we ran a few months ago, trying to answer it from that perspective. Maybe if we have time, you could say what you think we could learn, because it may be that you're thinking, oh my goodness, what does this woman know? There are some fantastic things that could be brought across, and I would genuinely be very interested if people do believe that there were elements of COVID contact tracing that were effective or that could be brought across, and that is evidence, or at least a good argument to say that they could work in our setting.
I'm gonna say, use my chair's prerogative to say, I think before we get to building the apps, I think we need to understand people's their relationship with what they think about these illnesses and what they think they're supposed to do or what they are able to do. So I think in relation to, if you get a notification as a sexual partner that you know, and you know, I don't know exactly how it works, but you get notification that you should come in for testing. But with COVID, I think there are so many more implications in terms of you know, you're supposed to self-isolate. It has work, it has caring, it has all sorts of implications for your life. And I think that there are so many other you know, the kind of partner notification or contact notification comes with so many social inequalities that we need to be able to support people in responding to the information appropriately. And I think sexual health has done a lot of work on that over the many years. So I think, in fact, COVID could learn from sexual health in a lot of ways, which I think we're probably both agreed on in terms of that. So I think there's a lot that we could talk about. We haven't talked very much about COVID at this conference, apart from it looming over our heads. And I think we could spend a whole other 3 days talking about what we could learn from sexual health in terms of COVID. Thank you, Claudia. I think I see you've responded to Stefan's comments in the chat about you've put the Sequence Twitter account in and the Lustrum website. So those are probably the best places to find out more about your work. I'm conscious of time. I'm going to ask us to, we've published some polls, or I think we've published some polls. We'd really encourage everyone who's been in this session to just take 30 seconds and respond to those questions, so we can think about how we delivered this session and what we can learn from. But while you're doing that, Claudia, I'd really like to thank you for your time. This has been a really good session. It's been great to hear about your work and your thoughts and where we should go. And I think we've come up with some really good ideas in terms of or opportunities to work together to take things forward. So thank you very much, Claudia. And everyone, please fill in the poll very briefly, and hope you can join us at our next session that starts at 11:30. Thank you.
And thank you for indulging me. It was great fun, and thank you very much for having me.
Pleasure. Thank you.